29, that'd be nice. All right, we are live, so you guys can start.
All right. Hi, everyone, and welcome back to another edition of Tumor Talk. I'm actually live from the operating room right now, or at least in the core. This is a collaborative effort between the Journal of Neuro-Oncology and Lenox Neurosurgery, where we present typically recently published articles in the Journal of Neuro-Oncology. Today is a special day where we're continuing with our series of recent award-winning abstracts in neuro-oncology. Today's session is based on pediatrics and specifically looking at combination photodynamic therapy and fractionated radiation for diffuse intrinsic pontine gliomas. And so I'm pleased to have with us Georgios Skandalakis, and I think it was Kostas joining you. I can't see if he's on right now, but
yes, he's here.
Oh, great. Hey, Kostas, how you doing?
How are you?
Awesome. Good. How you been?
Great.
Well, welcome everyone. Why don't you guys introduce yourselves and get started?
Sure. So hi everyone. Thank you for the invitation and the introduction. My name is Georgios Skandalakis, and I'm a postdoctoral fellow at the Department of Neurosurgery at Mount Sinai. And I'm going to be talking about our research on photodynamic therapy for DIPG. I had the great honor and blessing to have Dr. Hadjipanagis as my mentor and the PI of this study. So I'm going to be starting. I have no personal disclosures, and here are the disclosures of Dr. Hadjipanagis. DIPG is a leading cause of pediatric brain tumor-related death. The 5-year mortality of the disease is 99%, and unfortunately, the median survival is only 9 to 11 months. Although more than 250 clinical trials have been conducted, the standard of care for DIPG remains radiation therapy, and unfortunately, the poor prognosis has remained unchanged. So in search for an effective DIPG treatment, we're investigating 5-aminolevulinic acid photodynamic therapy, which I will call 5-LA-PDT for short, in combination with radiation therapy. So 5-LA-PDT involves the oral administration of 5-LA, which has been FDA approved here in the US for fluorescence-guided surgery of high-grade gliomas. 5-LA is metabolized into protoporphyrin 9, which selectively accumulates in glioma cells, as they specifically lack ferrochelatase, the enzyme that would otherwise convert PP9 into heme. So PP9 is a photosensitizer and can be utilized in both fluorescence-guided surgery and photodynamic therapy. In fluorescence-guided surgery, the application of a blue light makes glioma cells light up red or pink, as you can see here. However, the application of a red 635 nanometer light generates reactive oxygen species, resulting in selective glioma death and the activation of the immune system against the tumor. So given that 5-LA-PDT has been proven promising in high-grade gliomas and malignant pediatric brain tumors, we hypothesize that this treatment modality will permit the enhancement of radiation therapy in DIPG. So in this study, we look into the intracellular PP9 levels after 5-LA administration in DIPG cells. Additionally, we evaluate the effects of 5-LA-PDT on tumor control and the radiosensitization of DIPG. So to quantify intracellular PP9 level, we performed fluorescence microscopy studies after the administration of 5-LA in both 5-LA treated and non-treated cells. And to evaluate the effects of 5-LA-PDT on tumor control and the radiosensitization of DIPG, we performed cell cytotoxicity assays. All of the experiments of this study were performed in the patient-derived DIPG 13 cell lines. Cells were obtained and cultured during early autopsy of a 6-year-old girl who turned out to have an H3.3 grade 4 tumor. Now here's the therapeutic scheme we utilized. So we performed photodynamic therapy 4 hours after we administered 5-LA. Additionally, we administered 2 fractions of radiation therapy 4 and 18 hours following photodynamic therapy. We then performed cell viability assessments at different time points following the second radiation fraction. So here are our fluorescence microscopy results and imaging. So in the top panel of this figure, you can see the dark field of 5LA treated and non-treated DIPG cells. And on the bottom, you can see the corresponding bright fields. And interestingly, we found 470 times higher PP9 fluorescence in 5LA treated cells when compared to the untreated cells. Now, switching gears to our more interesting treatment results. Here are the results of the 5LA PDT monotherapy studies. And as you can see, we found a marked anti-tumor effect 48 hours following PDT. And interestingly, we found no toxicity effects in cells that were treated with 5LA or light alone. And here are our combination treatment results. So the darker bars represent radiation therapy alone, which also served as a control. And the lighter gray bars represent photodynamic therapy in combination with radiation therapy, which proved to have a profound anti-tumor effect 24, 48, 72, and 96 hours following PDT. So in conclusion, the administration of 5-ALA had a pronounced increase in intracellular PP9 levels. 5-ALA photodynamic therapy had a marked tumor effect on DIPG and allowed for the enhancement of radiation therapy. So this study can provide a solid foundation for further translational work of photodynamic therapy in DIPG, as overcoming the radioresistance of DIPG will provide better tumor control, improved patient outcomes, and quality of life. Finally, a better understanding of the 5-ALA PDT tumor-specific immune response will open up opportunities for the investigation of adjuvant immunotherapies. And at this point, I'd like to acknowledge Dr. Hadjipanagis and all of my colleagues at the Brain Tumor Nanotechnology Laboratory, as well as Dr. Plakantonakis and his colleagues who had the courtesy to share some of their DIPG cell lines and also training me on working with them. So thank you very much.
Thanks so much, Georgios. Very interesting study. I wonder, have you guys, do you guys routinely biopsy DIPGs? And if so, have you used 5-ALA in them in humans or just cell lines so far?
Randy, this year we've done a couple biopsies of DIPG patients. We have not given 5-ALA to those patients, but I think now that we have some in vitro data, we haven't been able to find any other published reports on 5-ALA and DIPG with fluorescence. So, our initial pilot in vitro studies are promising in that in this patient-derived DIPG cell line, we did see profound fluorescence. So that may be something we consider with our tumors.
Well, the reason I ask is I've been experimenting a lot with the 5-ALA, and I've even used it now on some spinal cord ependymomas. Yep. And one of my thoughts about how this works, and you're going to be the expert on this more so than I am, is it has to do probably with tumor metabolism, right, to some degree, and how soon you're going to give it or how late you're going to give it the 5-ALA. And so I'm just more curious about, would you do it, initially based on the FDA guidelines, so about 4 hours prior or so, or do you think it needs to be given earlier? I guess, more study is obviously necessary before you get a good sense of that.
Yeah, we have a study we're kind of putting together for publication, but we looked at Walter Stumer's recent paper on this, and we agree with Walter based on our experience. We looked at our multi-center study in the US, and we definitely felt that the longer you waited, there was evidence of very robust fluorescence. Can we say it's better than it is earlier? I mean, I could say anecdotally, I like to wait at least 4 to 6 hours before I operate on 5-ALA cases. So that's what I incorporate in my practice now.
And how do you foresee this working again, just to, bring the translational component together? How do you see this working in humans? Because you would do the photodynamic therapy, obviously, in the DIPG, and then how long would you wait for radiation in these cases, or how long do you think that it might last, the photosensitization?
No, great question, and Yorgos, great job with the presentation. So I think, what Yorgos and others in the lab are working on is how we can take this to an in vivo model, and we're working on getting some specially designed laser fibers that we can use in small animal models such as the rodent. But the concept would be that we would administer it to patients, and then could you stereotactically place a laser catheter, a laser fiber. They're pretty small, 1 millimeter, 1 to 2 millimeters, and then perform the intraoperative photodynamic treatment, and then have them go on to the radiation treatments thereafter.
Very interesting stuff.
Yeah, there's a whole other aspect of 5-ALA that we've been exploring, and I think it bears a little bit of conversation by the group. I'd be interested to know your perspective, but 5-ALA is also a sonosensitizer. Not only is it a photosensitizer, a photodynamic sensitizer, but you can sensitize cells with ultrasound when they've taken up 5-ALA. And there is I believe the Toronto group is looking at 5-ALA sonodynamic therapy for DIPG, so that it would also be another potential avenue to use ultrasound to stimulate cells that have taken up 5-ALA. In this case, using MRI-guided focus ultrasound, and then to look at the downstream tumoricidal effects that it may have directly on cells, not just with radiation.
Yeah, that's great, Jason. I think that's a very promising area, and certainly minimally invasive. You wouldn't have to put a needle into the tumor in that approach. But I think these are all promising avenues that we need to explore. And part of the challenge is we have to have the right models to understand these with DIPG. That's always been the challenge, is how you can grow these in the brainstem and really study them. A lot of people just grow them supratentorially and use their models that way. But getting them in the brainstem is a little bit harder.
Well, I have to imagine also, the brainstem of a mouse versus a human makes this a lot more difficult to put a laser down in it, right? I mean, even if you can get it to grow.
But they're certainly challenging entities, and obviously there's tremendous opportunities to improve the outcome of patients using things that like 5-ALA. And we know that radiation is perhaps the most important, or one of the most important parts of treatment for these DIPG patients. So anything that you can do to accentuate that response, or potentially because you could give 5-ALA repeatedly over a time span of a standard fractionation course. You could give it over many different fractions. So I'm really impressed by the work done, and obviously tremendous opportunities to pursue this further with additional in vitro testing and in vivo testing.
Yeah, thank you.
Absolutely. So has this been published yet, or are you guys still in the prelim data stage at this point? I know the abstract was published.
George is getting stuff together, not yet, but we're hoping to pull things together. We want to kind of hammer out the animal model, so that's what we're working on right now.
On the tail end.
To show some feasibility.
Well, guys, fantastic. I think it's safe. We could probably end a little early today. Typically, we do a few presentations, but you guys were the gold award winners for this, and so appreciate your time and input. Jason, anything else to add?
No, I just want to again congratulate you on the work, and the collective team has done so much for advancing 5-ALA and 5-ALA based neuro-oncological research. So just outstanding work, award winning, I might add, and hope that you'll be publishing it in either Journal of Neuro-Oncology or some other forum for our audience. And then obviously love to see you at the tumor section next year. Georgios.
Thank you so much. Really appreciate it. I'm very grateful for the invitation and the opportunity to present our work. And thank you.
No way.
Thank you,
Yeah,
guys.
absolutely. Thanks so much, everyone. Looking
Thank
forward
you.
to the next session. So
All
we'll
right.
see everyone next week. Thanks
Thanks
for
for
tuning
inviting
in.
us.
Thank you.
Thank you.
Thanks. Take care, guys.
Bye bye.
Bye-bye.